welcome. Thank you for joining our seminar series. It's co-hosted by the O'Brien Institute for Public Health and the Department of Community Health Sciences. I'm Paul Runksley. I'm an associate professor here in the Department of CHS. I'm going to be moderating today's session. So we're very fortunate to have Aliya Kassam presenting today. Before we start, though, I'd like to recognize that the University of Calgary, located in the heart of Southern Alberta, both acknowledges and pays tribute to the traditional territories of the people of Treaty 7, which include the Blackfoot Confederacy, comprised of the Siksika, Piikani, and Kainai First Nations, Tsuut'ina First Nation, and the Stoney Nakoda, including the Chiniki, Bearspaw, and Goodstoney First Nations. The city of Calgary is also home to the Ottawa and Métis Nation of Alberta. And when I think about reconciliation, I know it means different things to all of us. And so for me, I've been trying to find more time to carve out space to learn. And so I just literally finished right before this, a course that Pam Roach is teaching through the Office of Faculty Development. It's called Reconciliation Leadership Foundations. She teaches it once or twice a year. And it was a really great space, just that it's a very safe space to talk about anti-racism in Canada and just thinking about your unconscious biases. So great course, really safe environment, and it was three-hour sessions, so really nice. If you are interested in that, she teaches it once or twice a year, but look on the Office of Faculty Development website for different times when they'll be there. So I have the pleasure. Oh, did I already messed up your slide? I have the pleasure of introducing Aliya Kassam to present today. She's going to be presenting on equity, diversity, inclusion, and accessibility in health professions education and its implications for a learning health system and public health. For those of you that don't know Aliya, she's an associate professor in the Department of Community Health Sciences, and she's the director of scholarship in the Office of Postgraduate Medical Education. Aliya's research is very diverse. It includes work related to residency physician training and competency assessment. She also does work on health professional well-being and career development, and also patient safety and health equity. She's an internationally recognized researcher when it comes to measuring stigma and discrimination towards mental illness. And she also is a founder of the Learning Wellness Lab called Wishes, which she started in 2019. So Aliya, thanks for coming today, and join me welcome Aliya up to the frontier.
Thank you, Paul. So thank you, everyone. I know you're very busy people, and so I'm grateful to have all of you here today. So I'm starting off with a picture of a river because I'd like to refer to medical sociologist Irving Zola's analogy for health. So a witness sees a person caught in a river current, and then this witness saves the person only to be drawn to rescue more of the drowning people. And after many have been rescued, the witness walks upstream to investigate why so many people have fallen into the river. So this story illustrates the tension between public health's protection mandates to respond to emergencies and help people who are caught in the current. But it also addresses that prevention and promotion mandate for stopping people from falling into. So with that in mind, I'd like to start today's seminar, and thank you for that wonderful introduction. So in terms of conflicts of interest, I don't have any to disclose. The images that you see here, unless otherwise specified, are from Microsoft. And I work within residency education. So many of my examples will be around residency education. But as a systems thinker, I'm thinking more broadly with health professions education. And here we also have our graduate program, who are training health policy leaders for tomorrow, but also thinking more broadly in terms of nursing, social work, and other professions as well. So often when we talk about equity, diversity, inclusion, and accessibility, this topic may cause discomfort because there's ethical issues involved. What's fair for whom in what circumstances? And so I'd like you to ask yourselves, why would it cause discomfort? Why is it causing discomfort? And if it doesn't cause discomfort, then why is it not causing discomfort? I'm very grateful to all of you for being here, as well as the people online. Thank you so much for joining us. And also the collaborators, co-investigators, the graduate students I've worked with, and all of the participants who have taken part in that research. And so if anything, I would love for you to leave today with feelings of empowerment as leaders in public health. So some of the many hats that I wear, Paul has already talked a little bit about them, but I am also the Equity, Diversity, Inclusion, and Accessibility Portfolio Lead for the O'Brien Institute for Public Health. I'm a co-chair for the advisory committee for CIHR for ethics and ensuring that we're applying ethical principles to health research across Canada. And the Wishes Lab as well really came about in 2019 when I returned from maternity leave, and I had learned that a bright resident physician had died by suicide. And just from lived experience, I thought this is something that cannot happen again. The research that I present today will intersect all of these different roles and hats that I wear. So the objectives for today are to describe the barriers to health equity in learning health systems, describe the role of health professions education in promoting health equity in learning health systems, and to apply an ethical lens to their role in public health, research, as well as practices. And so in the next slide, I'm going to talk a little bit about my positionality in terms of my identity, present you with a reflection question that I'd like you to think about throughout this presentation, go through some background and definitions, and then address the objectives that I stated earlier, and then get into some discussion. So we all come from unique backgrounds and we have lived experiences. And so I like to think of our identities as kind of this weaving together of multiple experiences. And so a little bit about me, I identify as a cisgender woman. My pronouns are she, her. I was born and raised here in Alberta. I was born in Fort McMurray. My parents immigrated from London, England, after living there for 17 years. But because of colonialism and colonization, they actually were from East Africa. Originally, their parents were born in India, but they retained their British citizenship. So that makes me a dual citizen of both Canada and the United Kingdom. I identify as someone who's neurodivergent, so I think in different ways, perhaps than the more neurotypical person. I come from a middle-class family, and my training is in psychology, epidemiology here actually, health services research, and ethics as well. So I have lived experience of stigma and discrimination. I'm also a wife and a mom who wants to leave the world a better place for future generations. And so I am passionate about health and well-being. So here's the reflection question. Would you rather be part of the problem or the solution in health systems innovation? So in thinking about some of the key background and definitions, health and well-being is a human right, and hopefully we all agree on that. And so being able to achieve that health and well-being corresponds to a person's ability to pursue their goals, acquire skills, education, and growth. And this broader notion of health recognizes the range of social, economic, and physical, as well as environmental factors that contribute to health and well-being. And ultimately, we hope that health is actually delivered equitably so that we actually are being fair and there is ultimately justice, which is an ethical principle. I love this image, and it's actually got a Creative Commons license, so you can use it in your own presentations. When we think about inequality, we see that the system basically is geared to advantage and one of the groups as opposed to the other. And then when we think about equality, where you're giving the same tools, you have that even distribution of tools and assistance, but the system is still advantaging a particular group or particular groups. And thinking about equity, we try to customize tools that identify and address those inequities, but ultimately we want to hopefully aim for justice. And that's fixing the system to offer equal access to tools, resources, and opportunities. And so why is equity, diversity, inclusion, and accessibility important? So equity really is about collectively dismantling those systemic barriers and considering those underrepresented groups. diversity is valuing all perspectives and those lived experiences that bring such richness to every aspect of health and well-being. Inclusion is about thinking about people who may not be represented, and thinking about inequities and power and privilege. How do we co-create respectful and flourishing communities and healthcare systems? And accessibility is making that information, those tools, environments, as meaningful and as accessible to as many people as possible. So the Government of Canada, and I'm sure you can find other references for what we refer to as equity denied groups, include women, Indigenous people, people with disabilities, racialized people, and also people from the 2S LGBTQIA+ community. I mentioned power and privilege before, and this wheel actually I found from the Alberta Teachers Association website, and what it illustrates is that the inner circle, the inner ring, is people who have the most power and privilege. And as you kind of move outside of the ring, you're then moving into more and more marginalization. And when we talk about power, we mean the ability to influence decisions, control others, whereas privileges is that unearned advantage granted to individuals of groups based on their social identity. And so in looking at that wheel, we all have areas where we have power and where we have privilege and where we might be marginalized. Similarly, so important to public health are the social determinants of health. And so if we think about power and privilege, and we also think about the social determinants of health, we can actually kind of consider how the social determinants of health might afford power and privilege. Okay, so I'm signposting my objectives because it helps me, and hopefully it helps you as well. So objective 1 is to consider barriers to health equity. And Paul, you gave an excellent introduction in terms of the course you've been taking with Dr. Pam Roach. And unconscious or implicit bias is one of the barriers. And that's not to say that you could never have unconscious or implicit bias, because as human beings, we all do. Implicit biases can be positive. They could be a preference for something or someone, but they can also be negative as well. And implicit biases are formed over a lifetime as a result of exposure to direct, indirect messages. We know that social media plays a big role in this. Implicit biases are pervasive, and like I said, we all have them, but they're changeable. And research shows that this process takes time, intention, and training. Implicit biases can lead to discrimination, which is another barrier. And so discrimination is an action or a decision that treats a person or a group differently. And this could be based on identities, including those groups who are equity denied. These reasons or characteristics are also grounds and are protected under the Canadian Human Rights Act. And so when we think about another barrier, we can see that from our researchers actually here based at the UC, marginalization of patients and health professions, learners. And I would say learners in general. But in thinking about those different systems, if we are marginalizing our learners, what does that mean for the downstream effects on healthcare for patients? And lastly, disparities in Canadian health leadership. And this is not to say that things aren't getting better, because they are. And the Cummings School of Medicine has a wonderful pathways program. And I know that the offices in terms of, can't remember the name, but it's the health equity and precision health offices that are creating spaces to ensure that we have equitable pathways. And in terms of residency education, as well as continuing professional development, it's promising that these emerging positions around health equity and addressing disparities is front and center for their competency framework, which is due to be released in 2026. So there is hope. Okay, so my next objective is to describe the role of health professions education in learning health systems. And the whole notion behind a learning health system is to move away from research being part of that ivory tower and not informing care delivery. So we've kind of been in the middle phases of that knowledge translation and exchange, but there's still work to be done. And the learning health system is all about embedding the applied research and evidence supports within the healthcare system. So I like this graphic from the Alberta SCORE support unit for patient-oriented research. So simply put, health systems, learning health systems, iteratively implement and evaluate health improvement projects. And this cycle of continuous improvement hopefully should result in higher quality, safer, and more efficient care for patients, but also better professional satisfaction for healthcare providers. And so more specifically, learning health systems should include science, informatics, incentives, and culture that are aligned for that continuous improvement and innovation, with the best practices seamlessly embedded in the delivery process and new knowledge captured as an integral part and product of the delivery experience. And that quote is from the Institute of Medicine. So a learning health system, in theory, should promote health equity, increase the efficiency of healthcare operations, the speed and generation of research synthesis, update, as well as improve population health. So what I'm going to do is present the results of 4 relevant studies that I have been part of course, with the team. This is not an individual effort, that will discuss how actually we can use health professions education to better, I would say, support an equitable learning health system. And some of them, of course, raise barriers, but with barriers, there's also opportunities as well. So an emergency physician, Dr. Jennifer Graham-Waddell, actually, who's also a former student from this department, approached me and said that she's seen experiences of racism in the emergency department of the Children's Hospital, and she wanted to do something about it. So it was really nice to have a physician-driven project. And so we looked to interview a large range of healthcare occupations working at Children's Hospital. And unfortunately, racism was described as pervasive throughout the Children's Hospital environment, not only against healthcare providers themselves, but also seeing it against patients and caregivers. So there was a sense of othering, and there was barriers to reporting racism as well as gaslighting. So the implications for public health are, if we don't actually have a safe training environment or healthcare culture, this obviously impacts healthcare delivery and would contribute to a learning health system that could be inequitable. So I have a few more slides that are going to show some quotes, and I'd like you to read them and to reflect on them as I present today. So in this quote, we're already seeing that one of the healthcare providers feels that the Children's Hospital is already not a safe place. And in this quote, we are seeing that healthcare providers are being discriminated against. Unfortunately, in this quote, we're seeing that Indigenous patients are treated differently. So another research study, this time learner-driven, was looking at the demographic data of medical students across Canada. So a former medical student from our medical school, who is now a resident, said, no, I don't actually see the population reflected in my class. And little is known around collecting demographic data, and we collect on gender identity, but we don't collect other metrics. And so in thinking about capital as a framework, this is Pierre Bourdieu's framework of social capital, economic capital, and cultural capital. We conducted a survey across Canada, cross-sectional, so of course there would be methodological limitations there, but it gave some insights. So we had a good sample across all the medical schools. At this time, there were 17. And we had a 25% response rate. And I understand that 75% is not accounted for. But really what we found is that there was a lack of diversity in the medical student population across Canada. And in terms of capital, medical students already had that social capital, that cultural capital, as well as that economic capital. Many of them identified as having one or both parents in who was a doctor, or a romantic partner that was a doctor. And so it's interesting that 86% of participants whose household income fell in the highest income bracket were a part of this sample. Also interesting is that debt was not an issue for these students. And in thinking about rural training, where we have disparities, 62% of participants reported that that would not have any influence on their residency specialty of choice after medical school. So implications, so despite best efforts, and I know the Cummings School of Medicine has, like I said, pathway programs, but also other applicant programs, are we actually admitting people who represent that population, our population of the social determinants of health that might lead to inequity? And so when you think about social capital, economic capital, as well as cultural capital. And in terms of the impacts on public health and the healthcare system, these are future physicians and who will contribute to a learning health system. And so then if a learning health system is supposed to, in theory, promote equity, are we then promoting equity through our admissions processes? So the third study was a needs assessment, and we looked at faculty and learners here at the Cummings School of Medicine. And we wanted to find out their perceptions about equity, diversity, inclusion, as well as accessibility curriculum. And so this was a needs assessment that was distributed by the dean as well. And we were targeting educational leaders, and that's why our response is smaller in terms of numbers. So 78 faculty members completed the survey and 110 respondents were learners. And then we also had follow-up interviews with the educational leaders. So what's working? So that in terms of what would help EDIA at the Cummings School of Medicine, this would be mandatory foundational training, diverse faculty hiring processes, and the availability of EDIA-related programs. However, a barrier was perceived resistance from those in power. So leadership is really, really important. And there's limited time for educational sessions. Often, EDIA is seen as unnecessary or just an add-on. Unintentional harm also came up. And so there is a willingness for equity, diversity, inclusion, accessibility curricula, but there's also a fear of unintentional. So what about the learners? Similarly, it was viewed as an extracurricular add-on. And also learners perceived that as perceived by their program directors and faculty. Often it was just a mandatory guest lecture that was not intentional, and it was more a tick box exercise. and it often wasn't connected to previous learning. So as public health scholars, I think there's an opportunity here to help in terms of how do we actually make this intentional? How do we include it in our curriculum? And so opportunities for growth and development included thinking about intergenerational differences, also thinking about disability and ableism, as well as intercultural competencies. And then thinking about our learning health system, how do we change culture? How do we ensure that our next generation of healthcare leaders who will be part of a learning health system are actually aware and trained in health equity? And in terms of focus groups, these are some of the themes that have come out. So there is a desire here. One of the themes was brimming with desire, but nowhere to go. So we do have people who are content experts, but again, resources are always an issue. And does representation matter? Indeed, it does. And so even with different influences out there, EDIA still matters in this context as we go forward. There were questions about whether or not to integrate, but I think health professions education is an important place where we can integrate curricula and the health equity piece. And it's really about being authentic and intentional in terms of practicing rather than performing. But of course, there is a hidden curriculum, and perhaps what's included, we also have to think about what's excluded. So those are going to be some challenges. But overall, programs with clear alignment with EDIA principles and learning objectives facilitates integration into the curriculum. But leaders play a key role. And so when I look at the room today, and also the people online, even though I can't see you, I know that you're all leaders who can help raise awareness of the systemic and structural inequities. Okay, so the fourth and final study, which was conducted just recently by a graduate student who's now going into medicine here, explored the construct of just culture amongst patient and resident physicians in healthcare settings. And for those of you that perhaps don't know what just culture is, it's this construct where the healthcare system balances the need for accountability with the need for fairness and learning. And so we wanted to actually consider resident physician perspectives as well as patient perspectives. So we engaged the Alberta SPORE support unit. Residents are an interesting group because they are both learner and healthcare provider. They're a huge part of the healthcare workforce. And working in postgrad, this is something that I feel would be really helpful, is to empower residents who are almost into practice. So we had 16 participants and we held interviews and focus groups. And we ensured that both patients and residents identified as belonging to at least one of those equity denied groups. So what did we find? I'm going to go through the different categories. This was a grounded theory study, but perhaps some of this won't surprise you. So medical hierarchy and power dynamics was brought up by both patients and residents. Both patients and residents felt overlooked and undervalued, and also found it difficult to move around the hierarchy in patient adverse event reporting. So for those of you who are familiar, Alberta Health Services has the reporting system, the RLS, which is supposed to be a learning health system. There's also a lot of protectionism in medicine. And so having that lack of improvement and growth mindset can also be a barrier to a just culture. Fear of repercussions. This is something that came across in both resident physicians as well as patients. Resident physicians are at the mercy of their network because they need to secure a job after residency. Patients as well are in a position where they need healthcare. So depending on their status, that actually moderated whether or not they felt that healthcare was actually depicting a just culture. Often patients were labeled as the difficult patient, same with residents if they spoke up, and there was a blame and shame culture. So participants expressed fear of reporting, and they commented on the influence of power. And of course, having an intersectional identity also played a role in whether or not they would report. In terms of reporting, when they did report, there was actually a poor experience. So there was lack of communication and follow-up. Often they had to tell their stories over and over again, which caused re-traumatization and harm. And there were also system constraints and political influences as well. So those are 3 of the 5 categories, and these are the final 2. There are, however, facilitators, and it really came down to relationships. So having role models, having preceptors, having people who actually are working in the healthcare system that patients actually knew. Considering the structures as well was important. But actually, if we think about the different structures of how we can report, this might actually facilitate reporting. Communication, enhancing communication would also help with that, as well as support. So in my 14+ years of working in residency education, I can say that there is a majority that actually don't know how to use the Alberta Health System reporting system. And if they do, they're also scared. So there's some barriers that we can work on. And then in terms of strategies to improve just culture, leadership, I've already talked about, as well as role modeling, but having that accountability piece. So closed loop communication, stigma reduction and safety promotion is really important, as well as programs and characteristics to promote safe learning and reporting. So we have a lot of work to do. And I've thrown a lot of information at you, so I want to piece it all together for you. So we talked about the first study, which was experiences at the Alberta Children's Hospital. And there were stories about inequities and experiences of discrimination in patients as well as healthcare providers. And then we also looked at the admissions process. It was for medical school, but I would say that we need to think more broadly about health professions, education, admissions. Who we're admitting then goes through their curricula, and there's a lack of curricula around EDIA. And this, of course, is influenced by the institutional culture, where there is a want to have curriculum as part of educational initiatives, but of course, there's resources, there's issues around not wanting to harm. And then we have the fear of reporting in the healthcare system. So this cycle perpetuates itself. And so lastly, I'd like to address the third objective, which is to apply an ethical lens to your role in public health research and practices. So I'm going to leave you today with more answers, more questions than answers. But when we think about health professions education, when we think about the associations like the Canadian Medical Association, the nurses have one as well, there are codes of ethics, there are competencies, but these often remain removed from training, or kind of they're just like an end goal that is just there in terms of a document. But do we actually think about, are we causing harm in providing care? And what is ethically acceptable in healthcare? How can we reduce the stigma and discrimination in healthcare? Not only around equity denied groups, but around reporting patient safety events or adverse events. And so how do we promote that safety? How do we ensure accountability and justice, which is fairness? And then how do we appropriately engage learners in the learning health system? I'm also thinking about the Hippocratic Oath as well, which when I attended convocation last week for the Cumming School of Medicine, this was a part of the ceremony. And of course, part of that ceremony is to do no harm. And so thinking about what I presented today and the numerous studies, this is not new. This is not a new problem. The numerous studies out there, reports around inequities. Are we actually doing more harm than good? And so I started off my presentation with the river analogy. And so in thinking about a population health approach, we need to think upstream about those structures and policies, the systems, not only healthcare system, but also the education system, the higher education system, the health professions education system, accreditation, accountability. We need to think about our programs, graduate programs, health professions programs, the services that we provide, as well as the downstream impacts in terms of our patients and learners and the broader community. And so I started off with this reflection question: would you rather be part of the problem or the solution in health systems innovation? And I don't need to hear your answers, but I hope that you've learned something from this presentation. And I will leave you with a quote from Dr. Brene Brown around vulnerability, because this is not an easy topic to talk about, but vulnerability is the birthplace of love, belonging, joy, courage, empathy, and creativity. It is the source of hope, accountability, and authenticity. And so I hope that I leave you with hope today and you feel empowered to make a difference. Thank you.
Great, thanks, Aliya.
Thank you.
Excellent presentation. I would really like how you laid it out.
Oh, thank you.
Made us think about some really big picture topics. I've scratched a whole bunch of questions down, but I'll open it up for questions from the group here for Aliya, if you have any. If not, I'm happy to start off with questions. But are there any burning questions to start? Sheet here, I guess, for questions. So maybe the first one about a learning health system. And so obviously within a learning health system, it often requires integration across our different healthcare sectors. And then we've got Alberta Health Services now that's blown up into 4 different health agencies. How do you see that affecting health equity?
I think, like I said before, we're challenged, where there's challenge, there's opportunity. I know that it's a bit of a moving target, the way that our system is structured. My understanding is that we'll have Alberta Health Services kind of as an overarching body or some resemblance of it. And then, of course, there are those different aspects like Clear Recovery Alberta and Primary Care Alberta, etc. So I think that, you know, if there's truly a want in terms of health equity and ensuring that we have a robust learning health system, we will have that oversight with Alberta Health, but also within those different silos, for lack of a better phrase. But I think as health service researchers, public health researchers, practitioners, this is really where we can apply for funding through CIHR and ensure that we're having equitable learning health systems, because I feel that that is a place that they're trying to promote as well.
Good question. So you present the fact that there is no diversity in the medical students or physicians. Like a lot of them are associated with families are richer or have more physicians supporting them. So what is your solution for that? And what do you recommend?
Absolutely. So thank you for that question. It is getting better because we do have something called pathways. We also have the International Medical Graduate Program. So people who've trained overseas, we are actually having more spaces for international medical graduates. Their experiences, we've done another study on their experiences, which are not often positive, but I think that things are changing, just perhaps slower than hoped. I think also what's really important is community outreach and thinking about high schools and maybe even earlier than that, and thinking about if a person wants to pursue medicine or a health profession's career, how do we create an opportunity or opportunities for that? so that, you know, medicine and healthcare is not just about the elite.
It was really interesting, just to add to that, because it was really interesting that white privilege was really pervasive in medicine, and you brought that up in this presentation. So it seems like we're doing well at CSM in terms of cultural competency. Do you see other areas that we could be doing better? Like, I guess, yeah, like you kind of mentioned some already, but talk about it once.
Absolutely. I mean, having space to talk about this. So thank you for the opportunity. I think it would be great to have a journal club around health equity or EDIA. I think there's strength in numbers. So if we have a large mass of people with shared kind of mental models around equity, that will help. Bringing people together is always helpful. And
Is there a question online?
Mary Modale asked, wondering how we can make progress towards equity when integrated care requires ministerial and practitioner collaboration. Also, how can we collect data to inform our progress, i.e. we do not collect gender uniformly in the healthcare system, only sex is collected, race and ethnicity is not.
that's a huge problem. And so thank you for your question. I think that's where data needs to be collected. They're starting to be collected, but there's also kind of a downside of collecting that data because it could also be used for harm. And so there needs to be data governance and data stewardship principles in place where we're actually using that data to ensure health equity as opposed to additional harm. So I think we need to collect that data.
So if you had some ideas or in your research you came across community-based approaches that kind of evidence EDIA objectives.
Yeah, absolutely. So I was working more so with part of the studies were more so with learners as community, but in the Just Culture study, we actually included patients. But these patients were part of patient advocacy groups, so they already had a foot in the healthcare system. And so one of our findings was that we need to consider kind of perhaps the newcomers and groups that might not have that privilege with the healthcare system and engage them with community-based research.
Follow-up question. So I'm just comparing it from my own perspective. Like you say, international medical graduate spots are getting better. So when I came here, I am an international medical graduate. When I came here, Alberta accepted 80 spots for IMGs. Now they accept 40. So the capacity, the money that is provided for training physicians have gone down 50% since I did that. And sorry, the other one. And the other problem is that the capacity of the School of Medicine is not endless, limitless. So you have a capacity for like, let's say 200 people. So because physician, like becoming a physician is a money-making job, a lot of people are interested in like becoming a doctor. So rich families invest in it. So a person who's like is supported by a lot of money has a higher chance of getting qualified for it if they want to. They want to, for example, get a check mark of item 1 to 100 to be eligible to enter med school. They can invest in it with the money support. They can be successful. So if you want to like put diversity in it, you have to put some of those qualified people aside and include people with other diversities or less qualified. So this is a conundrum that I like based on my own perspective, and like I couldn't figure out from the presentation. That's what my question is.
For sure. Thank you so much. My understanding is that the spots have now increased. I can fact check that for you.
I do it every year. It like becomes from 42 from 40 to 42.
Okay.
Compared to what it was like in 2008, so that while I was here, it's still nothing.
Okay, because I know that we always get a grant every 3 years. So this might be something that's coming up in the next 3 years. And then to your other question, it's absolutely correct. This is what we found is that privilege breeds privilege. And so even if you are from an equity denied group or intersections of an equity denied group, you already have privilege and you already have perhaps that economic capital, social capital that affords you into that system. And so that's where I mentioned that community outreach, thinking about high schools and thinking about communities that we can actually nurture so that they can have a chance to get into health professions education. It's not easy. I don't have the answer. And like I said, I have more questions than answers. But I look to you as leaders and collaborators to help.
What I want to say is that it's okay if you don't have diversity because sometimes it's unavoidable.
Is it though? Is it unavoidable?
Well, I am from Iran. So in Iran, the medical school, entering medical school is totally different from here. It's 100% supported by the government. In return, you provide return of service. So it's a one entrance exam, first come, first serve. But the problem with that is that they, in order to meet the diversity, they divided into chunks of people. For example, this chunk goes to people who have done service to the country, for example. So those people have their own qualification system, but in comparison, they are not even compared to people who go from a normal, like an ordinary stream. So what happens is that you see a lot of people who are not qualified to come to be in med school, like compared to others. But because of like having that sort of their own method of diversity, you see 30% of the positions goes to people who are not even intelligence-wise proper for doing the medicine. Like that's an extreme version of that. But here it's less extreme. But what I say is that you have to consider that somebody who's qualified, whether or not they have reached family or support.
So I understand your point, and there's merit, there's competency. You have to ensure patient safety, and this person is capable of taking care of patients. But I would always encourage you and everybody in the room and people online is to ask why. Why are those inequities already existing within your context? And how can that change? Why are there people who want to be physicians and healthcare providers, but they're deemed less competent? Is it because of the opportunities that they've been afforded? Is it because of the political structures and the governance within their context?
Maybe the method of selection should change.
Absolutely. There's so many multiple factors. It's a complex adaptive system. But I think, trying to understand where those gaps are is kind of the first step to change, rather than just saying, well, this is how it's always been, and this is what I went through, so this is the way it has to be.
Definitely is not a fair method. That's what I'm saying. But what is the replacement?
So that's why you team up with healthcare scholars like Paul and myself, and we'll help with that. But really, I mean, there has to be a way. There has to be a way, because then systems of oppression just continue to perpetuate for years and decades longer.
Other questions?
In the sense that right now, when you're talking about presentation, you're talking about difference in terms of different qualities. But I'm also, I'm also helping researcher collaborators and people. And so one of the things that we also talk about is different knowledge systems. And so it's not always like you can have a provider who's from a diverse community, but they're not able to navigate, say, for example, a patient who draws on different medical systems, right? Biomedicine, the way they blend it, so many diverse communities have a long history of that. So I'm wondering if in your research, you encountered that challenge. I mean, it's an education challenge in the sense that, biomedicine is always about other systems. But when for some patients, there are other competing medical systems. So I was wondering if you encountered that research. I mean, I know it's not for every department, but it's definitely an interesting area for medical practitioners.
I would agree, and I thank you for raising that point. I think this is why we have all of these different holistic health clinics out there. And I think everybody's perspective needs to be honored. If that's what is seen as kind of their way for health and well-being, because there's not a one size fits all. Having said that, Irving Zola, he talks about the medicalization and medicine as oppression. And so I think there's a lot there that we can talk about, but I mean, we're in a medical school. We do subscribe to the biomedical model, but I would say that perhaps we need to consider not those alternatives, but understanding the intersections of people's identity and why they would want those alternative types of health care. And to be okay with it. I mean, that's something that we always talk about in ethics, right? If somebody wants to refuse transfusion, as a healthcare provider, you do your due diligence and inform, but it's then the patient's choice.
In your third study, you had brought up as part of the results, like faculty perspectives. And one thing that kind of stood out to me was, and I'm just reading off your slide, perceived resistance from those in power, limited time for additional educational sessions, and the perception that EDIA is unnecessary. How do we change that perception at the top? Because people that report to leaders are like, we want this, we see its value to implement it, but they're like, no, we're not giving it a time of day.
So that's a wicked problem as well. And this is where we need to think upstream and downstream, top and grassroots. And like this is the generational piece. I mean, unfortunately, we'll have to wait for some of the older people to retire, not trying to be ageist, but because the generational thinking is quite prevalent. But again, I think that not letting these conversations go silent, just because there's not kind of perhaps buy-in or it's not valued doesn't mean that it's not valued. And so continuing those conversations and that dialogue is really important.
I have a comment on that. I've been to so many talks where, like, I'm feeling for the people who program the content of the med school and PG&E and all those kind of things, because there's so many things. There's planetary health, EDIA, artificial intelligence, all these new things. You got to find time to teach them, and none of the old stuff has gone away, right? None of the content on like biomedical things and physiology, and how do you fit it all in?
And I hear this all the time. I mean, real estate on the medical school curriculum, residency curriculum, it's so limited. But this is where I think ethics comes into play. We need to do a better job of teaching ethics, because if you see the harm that can be done without considering health equity and intersectionality, that's a human rights violation. So I think that needs to be front and center. I completely agree with you, Jamie. I mean, there's so many competing demands, and my heart goes out to the people organizing the curricula and the learners. But I think it's really about, am I actually doing harm?
Thinking about harm as well. I just want to bring you back to I think it was paper four, project 4, related to reporting mechanisms for harm and adverse events, so to speak. How can we make that better or maybe safer so that people actually do report?
I think we need something that's completely standalone. And we have the Health Quality Council of Alberta. I know that there's a systematic framework, but all of this is predicated on the notion that people are reporting. So we need to reduce that fear, that stigma, that you're going to actually be punished if you report. And having an external body where you can actually do that, and there is a sense of accountability, I think that would be important.
Questions?
I hope I've left you with hope and empowerment. I know I'm not a health provider, but I hear stories all the time.
Really appreciate your expertise in this area of EDIA and also just your leadership and your passion in this
Thank
space. So I appreciate it. So join me in welcoming Aliya. Yeah. So this is our last seminar for the academic year. So we're going to start up again in September. So we'll have a new schedule out for you to look forward to in the fall. But if you don't see you, thanks again for coming, and we'll see you again in September. Thanks, everyone.
Recording.